Thanks, everybody. I'm working with a great team, and I just want to acknowledge them. So our journey, we've gone from kind of looking at and trying to solve world hunger to trying to narrow it down a little bit. So first of all, show me the harm. Where was our harm? A bit of a journey in learning where it was and what we could do and how we could get down there. And actually, it took us quite a long while to find actually data that would even support what we did or what we were going to try and do. And did we even understand that harm was an issue to us? Well, yes, it was. We found coding data provided us with lots of information about, yep, there's a lot of opioid-related harm. When we dived into our data a bit longer, we found that actually respiratory depression was quite a significant event, and we looked at where the areas that were occurring. Then we link it back to a patient. We had a patient, we had a very bad outcome. 67-year-old man, fit, well, came in for an elective surgery. Really no significant history, some question in his operative process that he might have obstructive sleep apnea, undiagnosed. He had a spinal anaesthetic, was using PCA. He had a moderate dose of opioids during this course, bigger doses of gabapentin, had low pain scores, was using his PCA as he had been taught in recovery quite well, found to be breathing very unwell. Shortly thereafter, had a PEA arrest and has had significant outcome and functional problems. So that we really looked at this, and yes, respiratory depression was a huge issue for us. And then we dove deeper into our data. So looking at it, when you look, we were able to present it, we looked at the whole of the organisation and looked at what it was, and we were seeing that a respiratory depression event was occurring in our organisation every 9 days. That spoke to our staff and engaged staff a lot more than saying that we have 0.156 per 1,000 patient days. So this was a great motivator for us to do things differently. But that was still big. That was the whole of the organisation. As we dug deeper into the data, we also learned that it was really primarily around our post-operative processes. So we looked at those a bit more. So we started our PDSA ramps, and these are the ramps that we were continually looking at and learning as we went around, continually learning about where we needed to focus our attention. And there's the next one, just and basically. So we continue to learn in that. We've done a lot of reviews with our medical staff. So what did the data tell us? Well, it is a big issue to us. We've been kind of aware and started to understand why are these things happening and what might be the modifiable things that we can do, because we came out from this big approach about where it was, but what are actually things that we could perhaps change the way that we provided care and look at how we should be doing those. It's focused, but it's also really focused our understanding of how our system does or does not work. So we've set up some measures and we're looking at those, and you'll also notice there's a few on constipation as well. But we also as I kept saying, dug deeper into the data, and we saw that our gynae patients are a real issue as well. So we're kind of really exploring that group because they're young, fit people. They have a lot of pain, and how we manage them is something that we're really working on. But we're also looking at a few other things about that, about what we're learning about them and what are some things that we could change in our practice. So some of those are documentations. When we started this journey, we thought we knew a lot of things and we had some good predictions, but we actually learned things are quite different than what we perhaps thought. We knew that constipation was an issue from our DHB data, and that remained true. We didn't really expect to find the levels of respiratory depression that we did, but they're occurring every 9 days. And they're in a lot younger population that were there. And we've also found that coding data is useful, and we needed to scale down where we're going to focus to make any sort of a difference. So based on that, we changed our theory, and we've changed our driver diagram and narrowed the focus on what we're doing. So the current areas that we're looking at to work on respiratory depression are about identifying those who are at more risk. So those are the types of people that we're seeing that have obstructive sleep apnea. We've got a good process now in place for our elective patients, but we have not replicated that in our acute, so we're working on that. We're also looking at cumulative doses, so we have awareness of people, and that information is being transferred across to people, to the wards as well, so they've had high doses. So that's one strategy. Then managing those who are at risk. We've revised our naloxone protocol so it is much more user-friendly and can be done, and that you don't over-naloxone people. And that we have a trigger for a rapid response is that next thing that we're looking at. So people are at risk, where do they go after hours? How do we manage those? And then we're also looking at reducing risk. How do we start doing surgery? And the anaesthetic team is looking about opioid-sparing anaesthetics, particularly in our gynae patients who have high need for opioids post-op, and we're looking at some different things around that. And we've been, I believe there are other teams who've done some good work on that, which we want to learn on. Patient literacy, so their expectation and how they're managing as well. Some of this is related to anxiety, and staff education about how we manage people. So we're now looking at, this is specific around respiratory depression events in post-operative patients. We're now starting to see a little bit of a difference. We were at 9 days, we're now, these events are occurring every 30 days. So, are we safe yet? Keep calm and do no harm and trying to find it. I think our key lessons is this is a continuous journey. The more that we learn about the system, the more areas of improvement that there are. Using patient stories and data help engage us in our teams, and taking clinical staff on the journey, I think, is really important. It's an improvement. It's a team sport, and we need to work together. Thank you, and I did it within my 48 seconds.